Ladies and gentlemen, welcome to this afternoon session here in South America. We are very happy that the room is crowded, fully booked. So everyone was like in church, sitting here 10 minutes in before, very quiet, but we couldn't start because of the online session, or the session will be streamed. So also a warm welcome to everyone who is following the sessions via the stream. The topic of our workshop this afternoon is battling neglected tropical diseases in times of climate change. As I heard from the sessions who already took place in this room, the climate or maybe the temperature may rise during the next 1.5 hours. So we will see how this will be managed. This session will be chaired by Achim Hörauf from the University Clinics of Bonn and myself, Carsten Köhler, from the University Clinics of Tübingen. And we are connected as we are both in the board of the German Network Against Neglected Tropical Diseases, who is also the organizer together with the VFR of this session. It's a workshop, and a workshop does mean that you also may be involved and putting up questions during the next 1.5 hours. It will become very sportive this time because there were so many distinguished speakers who wanted to present themselves here. Now we ended up with 7, so we will have 7 presentations, and after that, hopefully we'll have half an hour left for Q&A. So then I hand over to Achim to start with the program.
Yeah, thanks, Carsten. I think you have said it all, what is necessary for the introduction. And I hope we'll get a lot of more insight about the different facets of climate change and NTDs. So it would be, of course, far too easy to say climate warms things up and therefore NTDs change. No, there is a lot of other aspects we have to tackle here in this session. And I'm very happy, Carsten has already said this, that we have really a great list of distinguished speakers who I will have the pleasure to start with. And our first speaker would be Dr. Jerome Salomon. He is Assistant Director General at Geneva at the WHO. He is a medical doctor from training and has worked in a lot of infectious disease projects, and his portfolio is really large. You see a short listing of it: health coverage, communicable and non-communicable diseases. He was also a member of the WHO Executive Board, and currently he is very much engaged also in the NTD programs. And despite the virus struck you, I guess, thank you very much for still making it to Berlin, and we are looking forward to your talk.
Danke sehr and guten Tag. Good afternoon, ladies and gentlemen, colleagues and friends. I'm very honored and humbled to be here and so happy to see this overcrowded, overbooked room, but I hope a lot of people, a lot of colleagues are connected. So all these people committed to fight NTDs, really it's great news. I will take a moment to introduce myself. I am Dr. Jerome Salomon. I am a French professor of infectious and tropical diseases, and since April 23, WHO Assistant Director General, universal health coverage, communicable disease, non-communicable disease, and mental health. I would like to thank the organizers for inviting me to this important event. People, infective agents, vectors, food, and commodities are moving in an interconnected world. Environmental conditions influence pathogen transmission, reproduction, development, and genetics. The reproduction, development, genetics, behavior, range, longevity, and predation of vectors, intermediate hosts and reservoir hosts, and the feasibility and effectiveness of intervention. Climate change is exposing political, technical, and operational vulnerabilities in the world's collective ability to safeguard health and well-being and prevent, detect, and respond to diverse health risks as those posed by malaria and neglected tropical diseases. We have learned that we need to build resilient systems that require going behind an individual sector. Direct effects caused by rising temperatures and shifting weather patterns are altering the shared environments of people, animals, and microorganisms. This can be observed clearly with shifting habitats of vectors, which is influencing the direction and magnitude of disease transmission. In addition, climate variability is expected to have indirect effects on malaria and NTDs trends by hampering equitable development and disrupting health services. Climate change and resulting severe weather events accentuate the impact of many socioeconomic and environmental risk factors associated with malaria and NTDs. Climate change intersects with other challenges to people's health and well-being, such as conflicts, migrations, food insecurity, and livelihoods. The poorest and most vulnerable communities who are already disproportionately affected by malaria and NTDs are likely to bear the brunt of these changes. We have seen this in recent extreme weather events and the devastating effects on people and health systems in West and Central Africa, Sudan, and Pakistan, to mention a few. The scientific understanding of the links between climate and health is continually growing. However, a recent scoping review by WHO's task team on climate change, NTDs, and malaria shows that there remains a lack of comprehensive evidence on the impact of climate change on these diseases, particularly in low-income countries with high disease burdens. More data regarding the impact of climate effects on malaria and NTDs and the evidence to support adaptation are urgently needed from higher transmission settings where healthcare delivery is limited. As we gather here at the World Health Summit, there is a role for all of us to play to mitigate the effects of this complex climate crisis on health and well-being of especially vulnerable populations around the world. The time to act is now. Thank you.
Thank you very much, Dr. Salomon, for setting the scene and speaking about the commitment that we are very, of course, happy that this is recognized at Geneva. We stay in Geneva. Our next speaker is Dr. Bernadette Abella. She works in the Department for the Control of Neglected Tropical Diseases at WHO and also has been a member of the drafting group of the new roadmap, or the roadmap 21 to 2030. So this was a big piece of work that we are now everyone trying to follow and trying to score what has been reached and what is yet to reach. So in particular, she is, as a veterinary epidemiologist, she is in responsibility for the zoonosis and recently also the snakebites. Bernadette, the floor is yours.
Thank you very much, Achim, and thank you, Jerome, my boss. Very good job. Okay, so now we'll go on a sort of a journey of the realities of neglected tropical diseases and the complexity of these diseases within the context of climate change. The change of climate is not a new concept, right? For thousands of years, we have changing climate. What is concerning now is the rapidity of this process. Climate has a strong impact on migration, especially on the agriculturally dependent communities, and we'll be hearing all this from our panel today. So I will just sort of set the scene around what we will be hearing and why it is important to us, but also what we can be doing as a society together to mitigate the effect of climate change. In fact, many of these neglected tropical diseases that I mentioned affect mostly agricultural communities, these communities that have subsistence farming. And this is also where a lot of the NTDs are found, in these communities that are hard to reach often, that are under turmoil of insecurity, where there's bad water sanitation, but this gives you the ingredients for a crisis that we really need to be looking forward to mitigate. So climate change generates a lot of uncertainty about the future of the epidemiology of diseases we think we know, but many of them are changing. Not only has there been historically manifested as epidemics, so the endemic diseases are starting to move, change their face, and are no longer as stable as we think they are. And so as we move to elimination, eradication, we need to be thinking, how can we, our pace, accelerate so that we can get the job done before climate change changes the context so quickly. You'll think, for example, it is unlikely that snakebite and envenoming, of which we will hear one presentation today, will be affected by climate change. But actually, snakes are very climate sensitive, and their distributions are dependent on temperatures, extreme weather events. And as they change, the patterns of the snakes will also change. There will be also more opportunity for conflict between human and animal as the farming patterns change. So climate change is actually simultaneously reshaping not only the epidemiology of our diseases, but it threatens our health infrastructure and affects the health workforce and alters our foundational determinants of human health. These parallel effects will exacerbate the challenge presented by the evolving epidemiology. So as you heard from Professor Solomon, we've just conducted a study on climate change and malaria and NTDs, and we might assume that everything will increase, but there will be places where some of these NTDs will automatically decrease and some will increase. For that, we need better data, and that is something that Professor Solomon just brought up. Our data is not yet very strong around the neglected tropical diseases. It might be better in, the more developed countries where data-rich studies are being conducted. But as we see, for example, the arboviral NTDs, and we'll hear more about this, dengue, chikungunya, are generally predicted to continue their current surge. And in fact, last night we were saying, is it really a neglected tropical disease? It's moving rather rapidly across the world, and many populations are affected. So the global expansion in the population at risk seems likely, and this is not only for dengue, but also for diseases like leishmania. So their predicted effect of climate change on these diseases suggests that the effects on vectors and other vector-borne diseases are important. And you will have heard this morning, schistosomiasis was brought up quite eloquently in the first keynote. Also, actually, a vector-borne disease, snail-borne. So it's not only the mosquito-borne diseases, we have many other diseases. Think leishmania, think trypanosomiasis, where Bayer, for example, has been supporting the WHO program. So many of these diseases are very sensitive to our climate changing. So we need more comprehensive data to understand the epidemiology, to understand so we can forecast the trends that will approach. But there are opportunities for us to reinforce that data, for example, improving our surveillance system, looking at potential opportunities for integration and intervention systems. And also, as you heard, I come from the veterinary sector. I work in public health. We need that collaboration. We need that coordination across the sector so that we are looking more at prevention and the prevention at source. And so looking at also engaging with the other sectors in a One Health approach. It offers more efficiencies and will give us more sustainability in the long run. So convening stakeholders globally to advance knowledge on climate change, malaria and NTDs must be one of our collective moves. And here we are today, all of us from different walks of life, different organizations, civil society, academia, research, private, public. And we're all here to do our part to mitigate and try to find solutions in the future for climate health. Today is that opportunity, and we look forward to hearing from the panelists and then discussing with you on opportunities we can go forward together with. Thank you.
Bernadette, thank you very much. So now I'm looking forward to welcome Eduardo Gomenzoro. We said that we want today, in neglected tropical diseases and climate, we want to focus on 3 different diseases, and the first one will be dengue. And Eduardo is heading the global medical and scientific affairs of dengue at the company Takeda. And he's responsible for the strategic direction and operational activities related to Takeda's dengue vaccine. He has already more than 20 years experience in the pharmaceutical industry and holds an international executive master in management, an MBA in marketing, and a postgraduate degree in obstetrics and gynecology. And it's a pleasure to welcoming you in the room South America, as you're coming from Brazil. So, the floor is yours.
Precisely. Thank you very much. Guten Tag, good afternoon, boa tarde. It's a pleasure to be here. Thank you very much to the organizers for the kind invitation to come here and share what we are discussing in Takeda in terms of what we can do to try to control this complex neglected tropical disease, which is dengue. It's an honor for me to follow my esteemed colleagues from WHO, so it's a big responsibility to be here in this podium. I am an employee of Takeda, so here is my clear conflict of interest, but I like to say that my main conflict of interest as a physician coming from a developing country like Brazil is to really get faster control on these dire diseases that generate so much suffering and burden constantly, and we still are away from a final solution for that. Dengue is not new. Dengue is actually, we have a quite long history with dengue, as you can see in the beginning of this timeline. There are some interesting aspects of dengue. We know that there are 4 dengue virus types that circulate all over the world. And one of the facts about the way these virus types got dispersed is attributed to the movement of troops during the Second World War, for instance. So that's an interesting aspect. The other important thing is that WHO is constantly reinforcing the importance of dengue, as in 2019 we had dengue included in one of the 10 greatest global health threats by WHO, and now in 2024 we are seeing an even worse situation, and WHO is also reacting to this quite firmly. And Takeda has been trying to align on these needs and how to cope with those needs. The truth is that the incidence of dengue has been increasing very quickly. It's the fastest spreading vector-borne viral disease worldwide nowadays. The factors behind this are, of course, climate change, urbanization, travel, and also, as I mentioned, military deployment. Now, WHO has rated dengue as a grade 3 multi-country emergency. There are 3.9 billion people at risk of developing dengue across 129 countries, and we see the huge amount of cases each year. Dengue is not severe in each and every case, like some other tropical neglected diseases, but the amount of severe cases and even deaths is high enough to raise concern. This concern is on the endemic countries where I come from, for instance, and this is getting worse at the endemic country level, but it's also getting worse at the non-endemic level as well, as I will show. One of the things dengue has that is in common with other tropical neglected diseases is that we don't know exactly the burden of the disease. There is, of course, an individual burden when someone gets sick, or the immediate environment and people who are going to take care of this sick person is a burden. There is a societal burden, of course, in terms of the need to have public health measures to prevention and control, and the burden on the public health care system. And of course, there is also a economic burden. And when we start looking at tropical neglected diseases, we see this lack of data, as Bernadette was mentioning, quite clearly. For dengue, for instance, we looked recently at healthcare utilization costs across the world, and there is a clear lack of data on this, and we need to keep researching on that. Also, we need also to keep researching on how the disease pathophysiology behaves and how the disease interacts with our immune system if we want to develop efficient ways to treat it. We don't have yet a treatment for dengue, or if we want to find an efficient preventive tool to cope with how this complex disease develops. We are getting better at that. There are many factors relative to the virus, to our immune system, to how we can clinically manage the disease. And the more we know about this disease, the more we invest on this clinical and scientific research, the better we are going to find a solution to it. The relationship between dengue increase and climate change, it's quite clear. As Professor Solomon referred, we can see on the left-hand side of the slide the suitability of the environment to the dengue virus vectors. So I put it again, so we can see here that from 2018 to 2050 and 2080, the environment is going to be more and more suitable to the growth of these vectors. So we really need to find ways to cope with that, either tackling the vectors themselves or finding other ways to control the evolution of this disease and reducing the impact of these outbreaks. Travel is related to this growth as well, as we can see in this slide. And even in non-endemic places like Europe, the amount of autochthonous cases is growing year by year. In 2023, we had 130 autochthonous cases in Europe, and this year we are already over this number. We had 76 cases in France, 129 in Italy, and 8 cases in Spain this year alone. So we are above that number already. The way we need to cope with dengue is a multi-factor way. As we can see here, vaccination is only one of the factors we need to activate. WHO issued recently a very nice whole set of orientations in terms of communication strategies and how to activate communities. But there are some other factors like the surveillance, how we can keep sustain vector control, and of course, evidence-based clinical care. We are aligned with WHO critical actions to achieve our 2030 targets to control dengue, and this is a work in progress, of course. Now, arriving at an efficient and safe preventive tool like a vaccine is not easy for dengue. It has been decades since the studies around the dengue vaccine have started. And the platform that is used nowadays is the live attenuated platform. Of course, we are not using the wild virus attenuated anymore. We have a recombinant chimeric virus that is used in most of the vaccines that are either available or in development. These vaccines have to achieve a well-balanced immunological response against all 4 serotypes. This is a big challenge. There are epidemiological differences because having 4 dengue virus types, they circulate in a different way in each part of the world. We have to understand how this prevention tool is going to work. Then there is the thing about people who had suffered the disease before or not, and this has also to have to be understood, and we have to need programmatic needs, right? So in terms of schedule, code change, and other characteristics. Finally, in Takeda, we understand that controlling dengue should be part of the One Health approach. As Bernadette was saying, she's a veterinarian, and the part that belongs to animals here is most about the mosquitoes than anything else. But of course, there are a human part of this in which the vaccines, diagnostics, immunological, and host factors, as we spoke, and education of the communities is necessary. We also have the environmental part, in which climate change is playing an important role. And finally, there is everything about how we can better control the vector growth and how we can make sure our populations and the most vulnerable will be protected. Thank you very much for your attention. I'll be happy to engage in a discussion afterwards.
Eduardo, thank you very much, and we are so good in time, so brilliant. Let's continue like this. So as you mentioned, Bernadette is veterinarian, and all good things are three. Now I may introduce two more persons of this species. And now we are focusing, and that's, I think, the very interesting thing about neglected tropical diseases. These are 21, and they are so different from arbor vector transmitted diseases. Now we are shifting to snake bites and soil transmitted pathogens. And therefore, I like to welcome Dr. Martin Barassa and Professor Dr. Norbert Menke. Both are from Vétérinaires Sans Frontières. And Martin is in Nairobi at the moment and now with us online. So very warm welcome to you in Nairobi. Very good that it's working and you are with us. And Martin is the regional head of programs based in Kenya, Uganda, Somalia, Ethiopia, South Sudan, and Sudan. It's a quite big area. And he previously worked for Vétérinaires Sans Frontières Swiss. And then in South Sudan for 70 years as country director. He holds a bachelor degree in veterinary medicine and a master's degree in development studies from St. Paul's University. And I think you will start first, and then Norbert will continue, right? So then the floor is yours. Please, Martin.
Thank you very much, colleagues. I'm happy to speak to you today on the topic of neglected tropical diseases with a focus on snakebite and venoming. And I'm presenting this exemplified on the case of South Sudan, a country where we have worked for very many years. South Sudan, as you know it, is a new country and characteristically is politically unstable with frequent conflicts and displacements. Infrastructure is still generally poor and with very high levels of poverty. This is just an overview. The healthcare systems are underfunded, are weak, and has got policy gaps that are necessary to address key health challenges. Frequent climate-induced disasters do occur, and in this case, floods and drought. And currently, there are significant ongoing humanitarian needs. Now, about snakebite and venoming. Now, this is a public health emergency that generally is ignored in Africa. In fact, to call it a neglected tropical disease is quite some misnomer, or is usually misunderstood. It's very abstract in the minds of the African populations. Most consider snake bites as merely accidents. But nonetheless, we do acknowledge it's one of the 21 neglected tropical diseases. Globally and annually, between 4 to 5 million people are bitten by snakes. And out of these bites, it is estimated that up to 135,000 people die. Out of these, 30,000 deaths are believed to occur in the sub-Saharan Africa. For the survivors, about 400,000 suffer debilitating life disabilities, including up to 8,000 amputations. But even with this data, we believe that it is understated because we do know that reporting of snakebite incidences is quite poor, data is poorly gathered and is poorly documented. Incidences of snakebites are common in rural poor areas, and specifically those who are most vulnerable are children, farmers, herders, that is the pastoralists and the agropastoralists, and hunters who are most at risk. And of course, as I've said, underreporting is very common, and the data is therefore sometimes regarded to be very inaccurate. In a recent household survey conducted in Zimbabwe as a case study, findings were very interesting that up to 60% of snake bites actually are treated only traditionally. Only about 16% of snakebite victims are seen by healthcare workers. About 11% of victims actually receive no treatment at all. And about 14% of victims die before they reach a health facility for help. Now, in South Sudan, the floods is the main driver of snake bites. And in the country, it is considered a neglected tropical disease indeed. And key driving factors include conflicts that drive populations into, the savanna grassland areas, climate-induced disasters, floods, and droughts. Floods actually force people to be displaced from their traditional dwelling settlements or places. And drought, of course, also trigger movements of populations across the vast South Sudanese land. Displacements, migrations also do occur. These conditions create ideal exposure situations or risk to dangerous snakes. And snakes in South Sudan predominantly are by species, the vipers, the mambas, and the cobras. Some little rattlesnakes also are seen, but these are the most really dangerous species that are common in the area. And snake bites peak around the following circumstances during floods. Snake nests are flooded, forcing them to lurk around high grounds, where traditionally also is where you also find high human populations. Prolonged dry spells also force snakes to seek water for drinking around human settlement areas. Seasonal migrations that occur in search of pastures and water also force communities to travel through the savanna grasslands where a lot of dangerous species of snakes are to be found. And of course, conflict-induced displacements, which also force people to camp in areas that have got very high risk of exposures to dangerous snakes. The common snakebite risk factors in the country, as we have noted, number one, of course, is poverty among the rural and poor barefoot populations. Snakebite incidences are considered to be a disease of the poor persons. Climate change disasters, as I've said, floods and droughts. Rudimentary housing conditions, I think as exemplified by some of the photos I've shown you there. Livelihood activities that characteristically include people herding animals, hunting, gathering, or fishing in the swamps where snakes are to be found, displacements from conflict or flooding conditions, of course, limited healthcare infrastructure and services due to low investments by public authorities, poor documentation of dangerous snake species, and low awareness of snake bites management among the rural populations. As a way forward, we do recommend and we do advocate and lobby authorities to prioritize the prevention and control of snake bites through investment in rural healthcare systems and community risk communication among the rural poor. We also advocate that they align their strategies to WHO goal to reduce snake bites by 50% by 2030, and of course to focus more on surveillance and documentation of snakebite incidences, including the most dangerous snake species, the geospatial data on occurrences, the victim demographics, the peak times, and the treatment types. Thank you very much, and I will welcome any questions or discussions after this.
Martin, thank you very much. Now I hand over to your colleague Norbert Menke, Professor Norbert Menke. He's certified veterinarian since 1987 and then certified veterinarian for parasitology. I didn't know that there are two different things by that. He's member of the European Veterinary Specialists in Parasitology and is lecturing parasitology at the University of Hannover. The floor is yours. You need now the...
Thank you very much for the kind introduction, and thank you very much, Martin, for setting the scene. So I think I just have to...
First I have to do this.
All right. So as it was said, Vétérinaires sans frontières, Tierärzte ohne Grenzen, Vets Beyond Borders, whatever you want to call it, the German section. We are really active in all of this. And what Martin presented here very much, drought and flooding, movement of people and animals, very much the poorest of the poor. This is where we are acting. This is where we are passionate to really do our work. And I think and I'm a scientist by heart, but the best science is meaningless if we don't bring it there where it's needed, regardless whether it's the first statement. No, I think this is why we're all getting together here, and this is why we've been asked to be at the panel. I'm getting quickly into, we have several challenges identified, and I will concentrate on WASH and the One Health, besides all the others. And they go hand in hand. We are certainly concentrating very much on the animals, but animals mean life to the people in these societies. So if we have good production and healthy animals, we have healthy people and vice versa. So there we work. WASH is, and I mean WASH is known to all of you, and why do we bring in for one snakebite and then here for my short part WASH in soil-transmitted helminth is certainly access to clean water. And the pictures you can see here on the top is a completely different way of collecting water and then bringing it into your community than it is already on the bottom part. So clean water and sanitation and treatment of wastewater is something what we really need to do. I should also make a statement here. I'm talking about soil-transmitted helminths in the context of WASH, in the context of climate change. And I'm a parasitologist, and I will show you not a single slide with a life cycle. This is really hard to do, because usually we do that. But it's not a lecture, it's something just to stimulate the discussion later on. So our challenges are that we are working with the pastoralists in very, very, very remote areas. So we need to set up information and things there. We deal with, and Martin said that as well, with people on the ground. These people have poor access to both veterinary or public health or human health. They struggle and interfere with severe droughts, and now these days even more with climate change, severe flooding, and the pictures being shown by Martin as well. And therefore the awareness and underrepresentation of infectious diseases, here we talk about, or I talk about, or just emphasize soil-transmitted helminth, but you could go wherever, and certainly we heard dengue as well. So our contribution, I come already to a conclusion, so to say. So we are present in the field, and I summarized it in 3 topics. So the first one, awareness and education. You need to take the people along. You need to talk to them in the way they understand. And I mean, this is the same for us here in Berlin than it is down there. And you need to use the tools that they do understand, that they embrace what you want to do, and hopefully they then carry it over. So here it is to improve access to water, clean water, sanitation, and hygiene services. I mean, you see the picture in the top where a man is digging a well where you can get clean water, or beneath the trough where you then can water your livestock. Second is investments in water infrastructure and schemes, so water wells. This is very important because people in these communities have to go very far sometimes to get water. So if you have something like that, wells, you can get clean water, you can carry it at home, and you have clean water at home. Side note, they're carrying it with these traditional yellow canisters. Has anyone ever opened one of these canisters in the field and how they look inside? Okay, so you start there. And third, trainings of water treatments, water facility use, water management. So this is the whole thing where it comes all together, breaking the infectious cycle of, in this case, soil-transmitted helminth, ensure hygiene, so bring the knowledge into the families and to the people, and by that hopefully have some improvement on health. And then you need facility management. That really what you start to implement is actually being taken further. And with that, short introduction to something like that, what we do in Vétérinaires Sans Frontières Germany in these areas that Martin showed in the Horn of Africa, and later on, hopefully in the discussion. Thanks for listening.
Thank you very much, Norbert, for this great introduction to the SDH. Now we come to the next speaker, and I'm happy to announce Klaus Runge, so he's maybe different from the program. He is a Chief Health Equity Officer at Bayer, And before that, he has been a pharmacist and health economist by training, served at several pharmaceutical companies like GSK, Wyeth, and AstraZeneca in access questions, access teams, pricing teams. And we are very happy that you can speak about a disease that is actually a disease I've been working on for 20 years, onchocerciasis. So I'm particularly interested and think you probably have some news to tell us. Please, go ahead.
Yeah, first of all, thank you for having me today. I don't have any slides with me, so bear with me verbally. My company's mission is health for all, hunger for none. And it speaks to the two businesses that we're in. It's agriculture, crop science, and it's health, pharmaceuticals and consumer health. And it's pretty intuitive that climate change has a huge impact on our agricultural business. And we need to develop means to help our customers, our smallholders, to adapt. So we, for example, develop short stature corn that is more resistant to heavy storms and wind. So we can offer rice that needs 30% less water to grow and to be harvested. But we are also increasingly having a look at the nexus between climate and health in our pharmaceuticals and consumer health business. And there's one area, before I come to the NTDs, where we see that, for example, farm workers in Middle America present with kidney injuries early on in their lives, actually in their mid-20s. So when they're exposed to heat and high humidity to these heat bulbs, obviously it has a detrimental impact on kidney health. And it's called actually Mesoamerican nephropathy. So that's where we are looking into, let's say, ways of managing these patient populations, actually. And staying on the continent, I've just come back from Brazil yesterday, so I'm still a bit jet-lagged, so sorry for that. I had a lot of discussions with the Fiocruz on Friday on how to improve access to Chagas medications that we offer as a company. So that's one of the areas where we as Bayer have a long history and tradition of supporting patients in need. And I think Chagas disease is a great example, if you want to say so, of some of the aspects that have been risen by previous speakers. So the one is climate change. So we see that the vector is now more prevalent and endemic in higher altitudes, for example. So we see a geographical spread of Chagas infections. And secondly, many of the vulnerable populations that depend on agriculture, for example, on farming, actually have an even harder time with climate change, which fuels migration. So we see a lot of, let's say, Chagas infection being carried north, not just by climate change, but also by climate change-induced migration into the US. So that's why we, for example, also have developed a pediatric formulation of Nifurtimox, the Chagas treatment, specifically for the US. 2 months ago, I think we also received a registration for the product in Spain. So migrants coming to Spain, bringing the disease with them, passing it on during birth is an issue, and we need to think about screening initiatives, prenatal screening initiatives. So that's one area where we definitely look into this interconnection between climate change and health. Yeah? So in other areas, we have services along migration routes, for example, sexual and reproductive health services, where we have bases along the most prominent migration routes that may be also an ingoing, let's say, touch point for screening or even treating patients with NTDs. Now, coming to your question on further commitments, we have been helping fighting sleeping sickness, African sleeping sickness, HAT, for decades. We have committed to help eliminate Chagas disease, but we won't rest. Yeah, so it shouldn't be health for some; it should be health for all. So that's why we in partnership with DNDi, and also in partnership with the Swiss Tropical and Public Health Institute, have started to develop a compound called imodapside for river blindness and STH, also with the support of the University of Bonn, and which really adds a lot of expertise to it. I have to cheat sheet a bit on the numbers here. So STH affects up to 1.5 billion people on the globe. So it's a really relevant, more than relevant number. And river blind is roughly 200 million people. We really appreciate the partnership here with academia, with Achim Hörhoff's leadership, and with the other partners. And there again, we start seeing that temperature changes have an impact on various aspects of the disease, of the worm, and that is something that we will continue to have a closer look at in the months and years to come. The river blindness program is in phase 2. The STH program is in phase 3. And we would expect that there may be a dominance of certain worm species within a related group of parasites, depending on the weather conditions. We also see that, for example, the vector for African sleeping sickness, the tsetse fly, can now be found in higher altitudes in Africa and is now emerging in previously non-endemic areas. So I would say it's one of the burning platforms for us globally, the climate change. It touches many aspects, both on the food sector, but of course in the health sector, and here in particular also when it comes to battling NTDs. And I guess there will be more and more cases that we will also see coming up in Southern Europe. And that's why I'm pretty happy that at least, let's say, the many people who fill this room make me feel that it's not so neglected, at least in this group here. And I think we all need to herald the need for improved services, diagnostics, supply, and research in this field. And we definitely should add the lens of climate change to everything we do in this field. So thank you very much for inviting me today. Thank you.
Thank you very much, Mr. Runge, for this overview of BIA's activities. And of course, although the future, maybe we can go into the discussion later how long it takes actually to develop new drugs. But the next and last speaker is from Liverpool, my colleague Dr. Louise Kelly-Hope. She's a reader in One Health at the Institute of Infection, Veterinary and Ecological Sciences at the University of Liverpool, having been at the Liverpool School of Tropical Medicine before. That's where we know each other from. And since quite some time, she has been interested in doing research on migration and how much, so to quantify, how much it actually brings disturbance to NTD with regard to increased transmission, or as we have also heard, maybe sometimes reduced transmission. So what we really need is these quantitative data, and I think, Louise, you can give us some answers. So the floor is yours.
Okay, thank you. Thank you very much for the invitation to come and talk about challenges that arise for NTD programs with increased migration related to climate change. So this talk will be focused on the NTDs that are controlled and eliminated through preventive chemotherapy. So I'm just focusing on that, and they're eliminated through like mass drug administration, but also clinical care to patients. And there are 5 groups of diseases, of PC diseases, that are widely endemic in sub-Saharan Africa. And they cause a variety of disability, and several of them are transmitted by climate-sensitive vectors. So I just wanted to highlight the SBEN platform, which really provides a great opportunity to really understand the distribution of NTDs, but also start to understand it in terms of in relation to climate and migration aspects. it's a really great resource, and it's important. As you can see, they have many maps available, but the map here shows that there's many countries in sub-Saharan Africa that have all 5 diseases that are endemic and co-endemic. And, you know, it's a continent that is very vulnerable to climate change as well. So migration, let's think about this, the movement of people away from their usual place of residence, either across an international border or within a state. This is so variable for every country, and it really needs to be taken into account. It can be voluntary, forced, internal, international, long-term, short-term. It can vary in magnitude, and it can be driven by so many different things and different combinations of these. We really need to really understand what that means for endemic countries. Internal displacement in particular is of concern, especially in sub-Saharan Africa. And in 2023, an estimated 75.9 million people are living in internal displacement globally. It's an increase of 50% in the last 5 years, and approximately half of that is in sub-Saharan Africa. And the major drivers are conflict and natural disasters. So, and this is of concern because climate change is, you know, predicted to increase the frequency, intensity, and duration of these natural disasters, which will have a knock-on effect to migration and have major implications for NTD programs, which we don't even know about or understand yet. In terms of the challenge for NTD programs, I think the biggest challenges are that there's so many data gaps at the moment, knowledge gaps. There is evidence in the literature on cross-border, seasonal workers, refugees, IDPs, but what we really need to know in endemic and NTD endemic areas are really what are the migration patterns and challenges, how they're being influenced by climate change, who and how many people are being affected, and then where are the high-risk migration and endemic areas? We need to identify them so we can actually act on them as well. And are there temporal trends? And all these sort of questions lead into whether trying to improve surveillance and control. So how do these factors really affect transmission dynamics? We don't really know about that yet. And then how do programs quantify the population denominators? It's actually a challenge now, let alone with all the migration and issues. So what do we do? That has implications for mapping and surveillance. It has implications for distributing mass drug administration, whether people are treated, sometimes treated, or never treated. And that is really important, as well as people who are disabled by these diseases, very, very neglected. What strategies have we already got that we can adapt, and what additional strategies do we need? And what sort of collaborations and expertise are required? We need to work with other people outside the NTD world. So it's very complex. There's many gaps. So to address this, to begin to address the gaps, an NTD NGO working group, we developed a risk stratification approach, just using national level data from the SPEN website, but also from the Internal Displacement Monitoring Centre website or data set as well. And we broadly grouped the data into high and lower risk areas. Very simply, it could have been done much more intricately. And we combined the information to develop a classification system, which we mapped, as you can see here, and color-coded. And the red are where the high-risk areas are. So these maps highlight a stepwise approach and help to identify particular countries that are very high burdened, not just in NTDs and populations, but also a lot of displacement that is driven by conflict and climate. And you can see that down the bottom, there are 4 countries in particular that are very high burdened countries that have high numbers of displacement, but also high rates. Yes, they're high populous countries, but they also have high rates. And DRC, Ethiopia, and Mozambique alone in just 2021 had around over 9 million displacements recorded. So it's also important to consider the disaster if you're thinking about the natural disasters and disaster type. The frequency within each country ranges. The floods were the most dominant natural hazard that were reported, representing around half. and 11 countries reported 150 flood events, which resulted in nearly 1 million internal displacements. Now, the tables are a little bit difficult to see, but the top square, if you like, is really highlighting the total number of natural disaster displacements. And there's 2 countries that really have high numbers of displacements. But there's other countries, they might not have as many people affected, but they're having lots of frequent events. And so that brings different challenges, if you like. So if we're going to develop any strategies, we've got to think about the disaster type, the magnitude, and the frequency, because the strategies just might be different. So just as a second case study, before I finish, is one in Malawi, where they had Cyclone Freddy put a major disaster. And this is, I've worked in Malawi for a long time, and this area has been affected time and time again with cyclones and tropical storms. But we also know it was widely endemic for LF. It has been eliminated as a public health problem, but there's patients still there, right? So there's many patients there with disabled conditions, men with hydrocele who are requiring surgery, and people with lymphedema that need clean water and sanitation to actually care for their conditions. So they already have limited mobility, and let alone flood and displacement coming there. So with this, it triggered in the area in the southern African region 1 million internal displacements across 6 countries. Malawi was particularly affected across these districts listed here. And we'd done some mapping. We'd worked with the Ministry of Health to develop maps of the cases across the country. And that really gave us an estimated idea of how many people might have been affected. We don't know how they're affected. That study hasn't been done. But we can see that in the southern region of Malawi, there's an estimated 13,000 people affected by lymphatic filariasis clinical conditions. And in the districts there that are listed, it was around 6,000 people potentially displaced or affected by flooding. And this is an area that's been repeatedly affected in the last 5 years. So it's a significant impact on people who have these disabling conditions in terms of movement. They're stigmatised, they're in pain, and they have mental health conditions as well. So just to finish, there's very broad recommendations. There can be many recommendations, but this is just adapted from a list from our previous paper, just saying we need some strategies, some preferred strategies, standard strategies to begin to address these issues, bringing the data together so we can start to make sense of it. We can't make any decisions or strategies without having that information together. And it would be great to know whether we can bring that data together to support decision support tools to help national programs to assess risk and make decisions, and also to increase advocacy, communication and research around these topics, because it's quite a neglected topic. So I'll finish there, just in the interest of time. Thank you for your attention.
Thank you so much. And it's now 2 minutes to 3. So as promised, 32 minutes are left for questions. So the workshop was now mainly with the speakers. Now we will put the work on your shoulders. And first answers I may hand over to Jerome, and then the person is going around with a micro, and then please ask your questions or give your comments, crisp and shortly, please, that many can participate, and also don't forget in the beginning to introduce yourself. So, but the first response maybe to Jerome.
Jerome.
I'm waiting for the question, or do you want me to comment first?
Yes, please. You can.
Okay. No, first I think we can all say that we thank all of you, because it was really very inspiring and very clear presentation, so congratulations. Bernadette said something very important about climate change, which already happened in the long year of the planet, but we are now all convinced that it's very quick and it's fully related to humans' activity. So we are the roots, we are the causes, but we could also bring the solutions. So, and we are, fighting for the most affected people that are not responsible for this climate change. So that's something also that we have to keep in mind. And because you all talk about uncertainties, and we have to manage uncertainties, so we need to be very agile and to adapt a very intersectoral approach. I think that's something very important. All what you said, or I think all together in terms of One Health approach and seeing your backgrounds and having your intersectoral approach, I think is absolutely crucial. We also talked a few, but it's very important to talk about data and evidence-based intervention. So we could also invest in AI, in hub. How do we analyze data coming from environment, data coming from vets, animals, data about humans? So having a hub here in Berlin, WHO has a hub. So I think we should have a very intersectoral approach and platforms. And second point is about modeling studies, because we have more and more data and of course more and more modeling teams. So I think it's important to work with epidemiologists. We have innovation, we have research, we have vaccines. Thank you. And we may need also to ask other colleagues. I was thinking about the impact of urbanization on NTDs, because we will have more and more human populations living in cities. What's the role of immunity? What's the role of genetics? What's the role of behaviors? We have people that absolutely don't have any best practices against NTDs when NTDs are arriving in a new era, in a new area. And thank you also for insisting on conflicts, impact of natural disasters, and migrations. And Louise, you insisted on the evolution of migrations. Just to realize that the number of displaced persons in the world doubled in 1 decade. And we went with DG in Sudan, and the impact of conflict in Sudan is absolutely huge. We have more than 10 million people displaced within Sudan, but we have more also of 1 million people in Chad, so in a very poor country, trying to help people already displaced. So I think that's very important. And just to finish about the need to have a very urgent call to action. We need to be agile, but we need also to share experiences, to benchmark from each other, to listen to the most affected countries that have the solution. So how do we adapt more than a top-down approach, a bottom-up approach of finding solutions with the communities, with the families, with the countries? And we are opening a WHO Academy, so you are all welcome to join if you want to share some trainings or some benchmarking all together. Thank you very much.
Jerome, thank you very much. I see the first hand over there.
Oh, 3 hands.
On the right-hand side, next to the lamp shining, though this gentleman with the red score.
Thank you, Carsten. Christian Grübenow, also from Veterinaries Without Borders. I have a short question to the colleague of Takedo. We heard about that vaccine, and thank you all for presenting. It was very interesting to listen here from the back. And we talked about how complicated it is to develop new medications and understanding the transmission of viruses and others. But my question goes for the, let's say, giving the access of medication, especially also for the new Takedo vaccine against dengue to the world. What strategies do you have? I underline it with a small example. It was like 3 weeks after the vaccine was valid. I go for a travel vaccination here in Berlin. I get it. I asked my colleague in Nairobi, did you have that available? And he said no, and I said okay, but the burden of the diseases at the moment is still bigger in Nairobi than in Berlin. So maybe you understand the question. I know you're a company, but what strategies as a company you have maybe to make sure that vaccine, which is very important, gets also to the people which are really needed, not the people which might be not the people in Berlin. Thank you.
Thank you very much for the question and for the opportunity to share a little bit on how we think about that and what we want to do about this. So first and foremost, it's absolutely clear that the most important burden of dengue is in the endemic countries, like my own country, which had a threefold higher amount of dengue cases from 23 to 24, and we are talking about millions of children that were infected. So one way we have to tackle this is to have a strong partnership with public institutions, public health institutions. In our case, it's also Fiocruz in Brazil. And Fiocruz is very much capable of helping Takeda ramping up the access to the vaccine. The other way is to work on the production, because we are catching up. We are really catching up. So this disease is evolving really quickly. We believe we're confident on what we were able to develop in terms of a preventive tool. We now have to produce enough. And we are very lucky to be able to have a contract with BioE, an institution in India that will help us producing 100 million doses per year in a few years in the future. But we are ramping up production from now to then. In terms of Africa and other countries that are in the developing world, we know that the access to vaccines is not that easy. The structures, the logistics are more complex, and we are also working on that to make sure that we are able to get where people are most in need. So yes, we are going to still have the vaccine available in vaccination centers in Berlin, but we hope that many more people in the developing world will get this as soon as possible. Thank you.
Thank you. Clear answer. So, Achim, are your eyes sharper? So which one is the next? This lady over there. Yeah, you. I think it's enough time for all the other questions also.
Hello, I'll stand up so that I can see you because I've been like this the whole time. My name is Riley Terzopoulos, and I'm with the Global Surgery Umbrella, and I also have a history in pharmaceutical manufacturing. And so I think today what I've really taken out of it is innovation is the key to the next steps in managing neglected tropical diseases. So on that note, my question goes out to everyone on the panel, and that's how do we include the communities that are affected, not just in the benefit sharing of vaccines or research, but also in the processes of creating those? Thank you.
Thank you. Who want to start? Maybe Martin in Nairobi.
Thank you. I think that's a very important question, and especially for snake bites. And as I did mention earlier, that in this part of the world, snake bites are not necessarily regarded as a disease. People think that to be bitten by a snake is accidental. But I think in terms of how we engage with communities to create awareness and to sensitize that this is actually a neglected tropical disease is through awareness campaigns. The awareness campaigns focuses on educating people on how to avoid risks. So we are talking here about risk communications in terms of protective clothing when venturing into areas which are known to be inhabited by dangerous snakes. But in addition, also referral mechanisms or help-seeking behavior. As I said, in most countries in Africa, for snake bites, up to 60% of victims don't seek even medical attention. So some awareness on health-seeking behavior, that every snake bite, whether the snake is perceived to be poisonous or dangerous or not, be referred to a health facility for management. And of course, as I said, investments in healthcare is very poor, and facilities are in some cases even non-existent. But a level of awareness and advocacy with governments, authorities on prioritizing investments to make sure that communities can access the much needed healthcare for management of snake bites when they occur. So the underlying thing here is awareness, sensitization on what snake bites is, what it means, how it impacts their lives, and how the cases that occur can be managed in a safe way. Over to you.
Yeah, thank you very much. I think I would like to stay with snake bites for one more question from my side. What I always think, is there any way of trying to approach this issue by an active vaccine? Because, I mean, if you had an active vaccine, you could just mitigate the risk a lot. And I understand that this is difficult for various reasons, but maybe we can shortly talk about it. Bernadette, do you want to say something on that?
There's such diversity in snakes that it'll be difficult to get one size fits all. But then I'm not the venomologist here. I think I'd like to keep the conversation sort of concrete around this. We love innovation, and it's really important. And Wellcome Trust is putting money into, new drugs for antivenoms, but that's a long way ahead, right? We need to do something now. We have antivenoms, but nobody's really interested, and WHO is trying to look for partners to build a sort of either a pooled procurement system or some type of financing facility. And that would help people now from dying. About the innovation, and we'll keep to snakebite just to give a concrete example. WHO includes communities or representatives from communities and civil society to design target product profiles. And what are target product profiles is basically, what should a product look like in order, not only about the technology around what, let's say, an antivenom should look like, but how can we deliver it in the population? So it's really trying to putting together a recipe on the best type of formulation, but how that formulation gets to the population. So I think that's really good. And I think one other innovation around communities' participation in NTDs, we heard about how many people seek traditional care, and it works for many things, not for snakebite or for rabies, not the venomous ones anyway. And deaths on the clock of a traditional medicine is no good for the business either. So, working with traditional healers so that they make the difference between what's a venomous bite, go quickly to the health facility and get treatment, and then bring them in the fold. That needs innovation with communities, and I think using snakebite was a great idea. Thanks a lot, Martin.
And I would like to add one point to the question. I think one of the aspects that is coming up in terms of development and implementation for vaccines, at least, is the realization that it's almost impossible to check all the boxes about how a vaccine works and what is the benefit and safety of a vaccine from the phase 3 trials. So what we are trying to do in Takeda is to really be very open to phase 4 trials initiatives like pilot regional immunization programs. We are going to take off with a few in Southeast Asia. So this not only helps us tackling the gaps that eventually the phase 3 trials have left, but it allows immediate access to populations that are really vulnerable and at need. So with this partnership with public health authorities in different countries, we are able, through phase 4 trials, to bring this vaccine faster to populations at need.
I took a different view on the question. Hopefully I understood innovation goes without question. We need it. But on the other hand, I understood it a bit more. Could we take information from the field to drive the direction of innovation? And here just a short statement is, like us, Vétérinaires Sans Frontières and many other NGOs beside the public organizations could bring our knowledge of our people that are really there in these communities back up the value chain to saying, look, all right, what could we possibly take from the learning that these people deal day in and day out in there? I mean, we do that in our societies. We ask doctors and veterinarians out in practice what is actually the need of a new drug, of a new treatment, of a new diagnosis, because they are there and they know it. So I think there could be a support from our end, from the people in the field, if I understood the question also into this direction.
Norbert, thank you. Okay, now the next question is going to the lady in blue, please. Okay.
Thank you very much for seeing me from the back. Appreciate it. I am Monique Wasuna. I'm from the Drugs for Neglected Diseases Initiative, working in Nairobi, from Nairobi. My concern is that I have heard about innovation and not about research and development, innovation, and then access to these treatments, and very little about treatments. We work in areas where you have to treat the NTD. For example, leishmaniasis and sleeping sickness, which I've had being mentioned. And these diseases affect the poorest of the poor. They live in the middle of nowhere. They live in arid and semi-arid areas. And so their voices must be heard. What is it that they need? And I think that if we don't treat them, for example, visceral leishmaniasis, where I've worked through from my younger life as a doctor till now, if you don't treat these patients, they die. So we must innovate and also make sure that these patients get the treatments. And if we want to eliminate NTDs, we have to work together, control, innovation, research, and development to get to the last mile. We need new tools to be able to eliminate these NTDs. So we cannot just maybe just only vaccinate, think of vaccination and alone, but we need to have new diagnostic tools. Most of these neglected diseases are very difficult to diagnose. New diagnostic tools, new treatment tools to reach the last mile and to be able to eliminate. We are almost there in sleeping sickness, where it has just come down, and because of innovation and research and development, we've developed together with partners fexinidazole, which you give for 10 days. And now the incidence is going down, and we are developing one treatment that if you take, that's the end. You don't have sleeping sicknesses anymore. So this is the dream. So I just wanted to make sure that we don't miss R&D, innovation, and access. Are these communities getting? Are we putting the ideas into what we are doing? Thank you.
Thank you very much for your comment.
Yeah, thank you. That's really important to keep both layers on the radar. One is the action that needs to be done now, the access, and what Bernadette has said, but also paradigm shifts can come with new research, and this was a very good example, and Takeda is another example. Bio will be another example, hopefully, when you go to registration. And maybe you can say something as we speak about the time that is obviously necessary. It's 10 years at least. How much is that from the I remember brainstorming, should Bayer do that or should it not do that? Until now, it's quite a long time, isn't it?
Yeah, it's. I mean, obviously, it depends on the disease area that you and the product you're doing research in, but it's more than 10 years usually. When we have an infectious disease, for example, the studies don't need to be as long as if you do as compared to research you do for cardiovascular disease, where you enroll 30,000, 40,000 patients over a couple of years to see the impact or the effects of a medication. So to me, and that's really something to also be aware of. I mean, we couldn't do this without partnerships. So I referenced the partnerships with DNDi and the Swiss Tropical and Public Health Institute that we're partnering with, academia that we're partnering with, because it is not of commercial relevance for us, this development. Yeah. So, in this context, the fact that the regulatory agencies offer an incentive for us as a company to co-develop with partners is key. Yeah. So. Earlier on, when I spoke about Chagas disease, I talked about the pediatric indication that we have developed for Nifurtimox. This was actually fueled by the incentive to receive a priority review voucher from the FDA. That's a voucher that you can either use yourself to accelerate a review of a file that you submit, so i.e. you can enter the market earlier, which is commercially and financially very relevant, or you can even sell the voucher to another company and cash in the incentive. So that's a very important component of holding up the research in areas that otherwise would not be commercially sustainable for us. And the same with the ongoing programs in STH and river blindness. There is an opportunity for us to potentially also get a priority review voucher awarded, which would then help us on other ends. also in terms of the availability of products in, for example, sub-Saharan Africa. Of course, we also need to get the products registered locally. Sometimes we have a pre-qualification that can be referenced, and it's not a coherent regulatory system in Africa. So we see the Rwanda FDA, for example, expanding its footprint. So as of next year, the number of countries in sub-Saharan Africa that would be okay with the Rwanda FDA approval grows from 6 to 13, so it makes it easier. But it's not like in Europe where you go to one agency and you automatically get the approval in 27 countries. Yeah, so it's oftentimes a country-by-country discussion that you have to have. And that's also something where I think when you think about NTDs, we need solutions that make it easier and more handy to bring these products into the system, also in terms of the regulatory framework. So oftentimes we would love to be faster, but we aren't. Yeah? So same with Chagas disease. We don't have the product approved in every country in Middle and South America. So again, it's a journey, country by country, submission by submission. So and I think there's also room for improvement on that end.
Would you mind summarizing shortly for us what the prerequisites for such a priority voucher are actually? Is it simple to summarize, or is it difficult?
That's where I would like to call the telephone joker. No, I mean it has to. There is different components. I mean, don't quote me on this, but of course there needs to be a significant disease burden, and there has to be a certain prevalence of the product, and also an acknowledgement that probably there is little incentives for a commercial organization to develop the product. So I will be happy to.
It's a long list. I got
to do some research on what the prerequisites are, but there is a set of commitments or a set of points you have to meet with the FDA and EMA. And as we see with the FDA, it's also to the benefit of the US population, because Chagas has crossed the border as it does in Spain too. So I have a AI.
The collaborators from the NDI have a comment or question to this. So maybe we just answer this question, then we go on with the other questions, if that's okay.
Hello, Sabine Specht, my name, and thanks a lot for all your contributions. This is a very, very important topic. And maybe to link everything back to the climate change, first of all, just a quick comment on the PRV. It's in principle really a substantial contribution from all of the partners to participate in this NTD space, basically. And then my second comment would be to bring it back to the patients, because I think whatever we do is really key, and Martin said it very nicely. It is key to know from the beginning what the patients would accept. That's number one, and that goes from injections over tablets, over, I'm not a veterinarian, so I pass out on the veterinarian field, but you need to know your livestock, how to take care of it. And we see a lot of, when being in the field, you see a lot of rejections, like, I don't want a pill. I don't want a pill from a white person, or you have a lot of reasons why people are not accepting something on the ground. So the second lack is that they often, as Martin said, don't know what the diseases are and how to really tackle them. And if there's no knowledge on the disease, we will also not deal with a migration of millions of people, because then they are out of mass stock and administration, or whatever tool we have around. Thanks a lot.
Thank you so
Thank
much.
you, Sabine.
So you pointed out that some gentleman here in the second row, or?
Yeah.
So it's already
hands up since a while. Sorry for that.
I couldn't see him.
Yeah, my name is Samir Saudi from the WHO hub here in Berlin, and actually my question has to do with the point that was just raised, and it's for Dr. Kelly Hope specifically. So one group of migrants that is often overlooked are like the seasonal or like cyclical migrants, especially through climate change. It will be more and more. how do we generate the political will? You mentioned like lack of data and like especially globalized data networks, the will to capture these migrants and these movement patterns, since often if it's within a country, there is often not that will that we have. If it's like a border regime, you actually track it across, European Union to Africa or to the Middle East. Within a country, you don't really have that. How do we generate that will to track that and to help with especially NTDs in this space due to climate change?
Well, the political will. Oh, is this on?
Yes.
Okay. Well, thank you for the question. In terms of the political will, specifically, I don't know, but I think it would have to probably come from the programs and to see it that this is a real issue in terms of reaching their elimination goal. They're not going to reach the elimination goal if they've got these patterns of seasonal workers. And this is what I said before, we actually don't know where they are. Defining where they are is really important. Actually asking them about their participation in MDA, mass drug administration, and so on. But I think unless you define the problem through the program, and then the program could potentially get some leverage to then politically involve and get some backing for that. But I think seasonal workers and cross-border issues are a particular challenge in many places, but they're not well defined, and we just need to define that to start with.
Mm-hmm. I have a question in context with that to you. When you said you extracted data from Aspen in order to define those hotspot areas where most of migration and conflicts are together, does Aspen actually feed this back to the national programs, these data yet, so that they, say, intensify the MDAs or just get more drugs to a different area in order to satisfy the need?
That could be the potential. So the data we use, they were downloaded from an open access database and examined in relation to the displacement data. How that might feed back, if it was national level data, I think that what's missing is subnational level data to actually get a much finer resolution on where the issues of population movement and migration and climate change are really happening. And they're quite a complex package to bring together, I think. I think on the last slide, and I didn't say it, but there was the NTD master plan. That's an opportunity to start to document from the national programs themselves, saying we have a problem around these borders, or we have internally displaced people, we have refugees. And once we start to get a picture of every country, and then we can start to see how it relates to the endemicity. We have quite good data on the endemicity through the SPEN data portal. So it's a matter of linking up the data and having a look at that in the simplest way. The other thing, just on the back of that, data is important, but being able to analyse it and make sense of it, we really need capacity and developing that as well. Not just more data, but more people being able to analyse it and keeping it quite straightforward as well. Modelling's important, but you don't have to do always modelling to develop practical plans and to make a step forward.
Thank you very much. With this, I hand over to Carsten.
Yeah, and as you all know, the rules are very strict here at the World Health Summit. Therefore, I want to say thank you to all of us working hardly together within the last 90 minutes. Especially thank you to the speakers and for your attendance. So enjoy the high-level panel tonight and the rest of the program tonight and tomorrow at the World Health Summit here in Berlin. Session is over.